Well, good afternoon, everyone. This is Sean Tunis from the Center for Medical Technology Policy. We're beginning the webinar on focusing on hepatitis C drugs, looking at evidence to demonstrate effectiveness and value. It's a joint webinar hosted by the Center for Medical Technology Policy and the Institute for Clinical and Economic Review. Briefly, the Center for Medical Technology Policy is an independent nonprofit that provides a forum to convene stakeholders to discuss approaches to developing, improving the quality, relevance, and efficiency of clinical research with a focus on patients, clinicians, and payers' evidence needs. In a moment, we'll introduce Steve Pearson, who can talk a little bit about the Institute for Clinical and Economic Review. So again, here's the conference co-hosts, myself from the Center for Medical Technology Policy. We also have from CMTP, Els Houtsmuller, who directs our Green Park Collaborative, and Steve Pearson will provide a brief greeting.
Oh, hi, everybody. I just wanted to say it's a real pleasure to co-host this with Sean and Dr. Houtsmuller. And I think we have a great set of speakers, and it'll be a great conversation. Thanks, Sean.
Great. So just a brief introduction before we get into our main speakers. As most of you on the call are aware, there's some exciting new treatment options that have become available for hepatitis C. They appear to have significant advantages over existing therapies in terms of safety, effectiveness, and overall patient burden. And they've raised some questions as they've come into more prominent use about what evidence currently is available and for clinical and policy decision making, and what evidence would be useful going forward to improve decisions by patients, clinicians, and payers. So to make sure that we kind of highlight the focus for this discussion, the GPC, that stands for the Green Park Collaborative, which is a program within the Center for Medical Technology Policy. And this collaborative provides a multi-stakeholder forum to support dialogue and consensus on methodologic standards for generating evidence of effectiveness and value. So because this webinar is being co-hosted between the Green Park Collaborative of CMTP as well as ICER, the focus of the discussion of the webinar will be forward-looking. In other words, what types of evidence would maximize the relevance and quality and efficiency of future research to inform key, what we call post-regulatory decision makers, patients, clinicians, and payers. So again, our focus will be forward-looking to future studies to inform these key decision-making groups. And this particular webinar is not focused on anything to do with the legitimacy or the value of current coverage policies. We're not here to debate the evidence requirements that the FDA uses to determine approval of breakthrough drugs, and the focus is also not on pricing of medication. So again, forward-looking, focused on evidence needed for to demonstrate effectiveness and value. Here's a brief overview of the agenda. With the introductions and overview, you see a list of our speakers from the FDA, Gilead, which is one of the main pharmaceutical companies with a key product in this space. Then ICER, a patient advocate from the Global Liver Institute. And then we have Michele Manos, who's a public health consultant and affiliated with Kaiser, but will be speaking from her role as a public health consultant. David Ross from the VA, and then Mark Godwin from UnitedHealthcare. Then we'll have some questions back and forth with the panel that I'll moderate, and then we'll should have a substantial amount of time for questions. The mechanism for asking your questions will be to use the chat box on your webinar screen, and we'll keep track of those questions, and we'll be posing those questions for you to the panelists. And again, our speakers are going to focus on what type of additional evidence would be most helpful to inform decisions by patients, payers, and providers. And the speakers will be talking about both research activities that are underway, as well as research that they believe is important and high priority to be conducted. And we're also looking for the speakers to comment on potential strategies, approaches, infrastructure, and partnership that would facilitate the production of this new evidence.
Hi, this is Els Houtsmuller, also at CMTP. What I want to do is just very, very briefly introduce each speaker. In the interest of time, we have a number of speakers, and so we can't really do justice to each person's background information, so we'll just mention everybody. This is in the order in which speakers will present. We have Dr. Poonam Mishra from the FDA, medical officer in the Division of Antiviral Products. Gregg Alton is also here. He's the Executive Vice President, Corporate and Medical Affairs at Gilead. Our co-host, Steve Pearson, who is the President at ICER, Institute for Clinical and Economic Review. Donna, who's the President and CEO at the Global Liver Institute. Michele Manos, who is a public health consultant, who was formerly the director of the Kaiser Permanente Viral Hepatitis Registry. We are joined also by David Ross, who is at the VA in the Office of Public Health, Clinical Public Health. And finally, Mark Godwin, who is the manager of clinical pharmacy at UnitedHealthcare. I just want to provide a very brief background, assuming that most people are familiar with hepatitis C and the enormous public health burden that it presents. This slide just shows you a little bit of epidemiology about the worldwide number of people that are presumably affected, and also specifically for the U.S. The one thing I want to focus on is the last bullet point, which is that treatment until recently, the standard of care could be up to 48 weeks of therapy, and the therapy was associated with serious side effects, also risks of drug-drug interactions, and burdensome dosing requirements, specifically injectable interferon. Relevant to today's discussion, Sovaldi was approved recently through the breakthrough drug pathway by the FDA. And just very briefly for a background, in order to be designated as a breakthrough drug, the drug must be intended to treat a serious condition, and there must be preliminary clinical evidence that this drug may demonstrate substantial improvement on a clinically significant endpoint over available therapies. So that is the pathway through which Sovaldi was approved. And the approval was based on high rates of viral clearance, relatively low risks of side effects. Other things to just mention about Sovaldi is that the treatment duration is shorter, and that for patients with particular subtypes of hepatitis C, it can be taken as an all oral treatment without interferon. Now, there are also a number of additional all oral hepatitis C medications that are expected to be approved later this year, and so this really is a new era. We now will start the speaker presentations, and the first person who's going to speak is Dr. Poonam Mishra. In the meantime, I just want to remind everyone that you can submit your questions through the chat box throughout the presentation. So as questions come up, you may submit them. We will address them. We may not be able to address all of them, but we will attempt to address them during the last part of the conference, which is the question and answer period for the audience.
Good afternoon. My name is Poonam Mishra. I'm a medical officer in the Division of Antiviral Products at U.S. Food and Drug Administration. I would like to thank the meeting organizers for inviting me to participate in this webinar today. Next slide, please. Next slide, please. Here is my disclaimer statement. Next slide, please. The sustained virologic response is used to determine treatment success. As you all know, SVR is an objective endpoint, and SVR12 is defined as lack of detection of HCV RNA in blood 12 weeks after completing treatment. SVR12 is currently the primary endpoint used in hepatitis C registrational trials. The ultimate goal of chronic hepatitis C treatment is to reduce the occurrence of end-stage liver disease and its complications, including decompensated cirrhosis, liver transplantation, and hepatocellular carcinoma. More importantly, achieving SVR correlates with improvements in clinical outcomes and is therefore considered a virologic cure. Next slide, please. So moving on to the rationale we used for some of the HCV trial designs which were used in phase 3 trials. These trial designs were put in place after numerous discussions with stakeholders at the forum meetings which were convened by Forum for Collaborative HIV Research, and input was also obtained at Part 15 public hearing convened by FDA. The rationale for using single-arm trials using historical control was that SVR is a highly objective endpoint, and the success rates which were observed with peginterferon and ribavirin regimen are fairly consistent across trials, such that defining a historical margin of efficacy was statistically rigorous. In fact, response rates seen in phase 2 trials were so much higher than historical rates, even in patients with poor prognostic factors, that allowing a single-arm trial in some of the phase 3 trials was well justified and considered sound. Another option was an immediate versus deferred placebo-controlled trial design, and this was used in subjects who were not considered to need immediate treatment. The purpose of the deferred treatment design is to collect comparative safety data. And at the end of the treatment, subjects who are randomized to placebo arm can receive the direct-acting antiviral-based regimen. Another option was placebo-controlled trial, and these were justified for patients who were interferon intolerant, interferon ineligible, so that there was no treatment option for these patients. Dose or interferon duration comparison were also allowed as trial designs. Once interferon-free regimens become available, an active control superiority or non-inferiority trial design may be preferred over single-arm or placebo-controlled trial designs. Next slide, please. So drug development programs should include as broad a population as appropriate. We recommend including subjects who are diagnosed with compensated cirrhosis in phase 2 and phase 3 trials. Also, we encourage the study of combinations of direct-acting antivirals in subjects with greatest need for new drugs, such as subjects with bleeding disorders, transplant subjects, and subjects with decompensated cirrhosis. In order to have these drug-drug interaction data is extremely important for certain specific populations, such as antiretrovirals for HIV and Hep C co-infected subjects, and DDI data for immunosuppressants for use in transplant subjects. Next slide, please. So what can be done in post-approval phase? Additional data may be helpful in determining the optimal regimen and treatment duration in harder-to-treat subpopulations. Moreover, regimens can be tailored based on patients' baseline characteristics, and these may help identify patients who can be effectively treated with shorter regimens. Demographic groups or racial or ethnic subgroups which are underrepresented in phase 3 trials can be specifically studied post-approval for additional data. There has also been a growing concern that clinical trials do not adequately represent the real-world patients. FDA signed a Memorandum of Understanding, or MOU, with HCV Target Group, which is an international research consortium of academic and community healthcare providers, to monitor observational data collected in real-world settings post-marketing. This will provide safety data in larger cohorts and in subpopulations which might have been underrepresented in clinical trials or may not have been evaluated in registrational trials. So comparative effectiveness trials are important and informative to compare the safety profile and the efficacy of various regimens. However, they are not mandatory. So I'll stop here, and I would be happy to address any questions later. Thank you for your attention.
Thank you, Dr. Mishra. At this time, I'll go ahead and turn it over to our next speaker, Gregg Alton from Gilead.
Hi, thank you. And I do not have any slides for this presentation or this webinar. I just want to start by again thanking the sponsors for putting this on. I plan to talk about what we have done and are doing to generate evidence for Sovaldi and the follow-on regimens that we're developing, but I'm also very interested in hearing from the other panelists and maybe from the questions about what additional data could be helpful, because additional data will help us as we bring more people into care and better understand those patient populations to improve outcomes. Our overall goal, I think, I just want to say up front, is to work with health systems, healthcare providers, policymakers, payers, regulatory agencies to achieve virologic cures in as many hepatitis C patients as we can, both in the U.S. and globally. And in doing so, we do take a pragmatic, science-based approach to do that. We obviously need to achieve regulatory approval, so we need the safety and efficacy data for that. But we also seek to have data that will allow us to generate the evidence for healthcare providers to understand how to use these products in broad patient populations. So if you take the first phase of what we did with Sovaldi, we conducted 6 phase 3 clinical trials with about 1,800 patients. That was really focusing on shortening the course of interferon for genotype 1 patients. But in addition to that, we also were able to look at all 6 genotypes as well as the different phenotypes of the patients within those populations and try to generate data up front to address some of the real needs of the population. So if you look at our first phase, we had about 20% cirrhotic patients, both compensated and decompensated. We had a patient population that really represented the racial makeup of the United States in terms of whites, blacks, and Hispanics in particular. We didn't have any age or BMI criteria with our enrollment criteria, so we really wanted to make sure that we had a patient population that had similar age as well as BMI. We had a number of pre- and post-transplant patients within the data that was a part of our label. We had both treatment failures and ineligible patients. HIV co-infection was involved, as well as hemophiliacs and sickle cell patients. So we really did make sure that within our first phase, and this is the interferon limiting regimen, that we had a broad as possible patient population, again, to generate the evidence to understand how to use the product with those populations. Moving forward into phase 2, as mentioned, that we will be moving to what we hope and expect to be interferon and ribavirin-free regimens this fall. we are continuing to look at expanding the evidence for patients. We have now phase 3 trials with about 3,000 patients. Be looking again at a broad cirrhotic population, about 41% cirrhotics in there, significant genotype 1 treatment experienced patients, which is something we want to have more data in as we move into the next phase. So we have a lot of genotype 1 treatment experience. We also will be looking, while these trials, this is for the Sovaldi ladipsavir, we'll be primarily looking at genotype 1. We will be generating some data in genotype 3 and other genotypes as well. Eventually, however, looking towards a pan-genotypic regimen, this is with our 5816 combination, which would come later, that hopefully will allow us to treat all genotypes with a short course of interferon and ribavirin-free regimen. In addition, this was mentioned by Poonam in her talk, is we are looking at duration of therapy right now as well. Are there ways that we can shorten the duration of therapy for different patient types? And then we're looking at that currently with both our registrational trials, but also outside of our registrational trials. So I think one thing we wanted to talk a lot about is what we're doing beyond, again, registration. But I want to emphasize a lot of what we're doing to identify the different patient types and the evidence needed is within our clinical trials, but we certainly don't limit ourselves there. So we're also looking at way to generate data in populations that tend not to be included in clinical trials, and these are in many cases populations of low socioeconomic classes. We're talking Medicaid populations, minority populations as well. So we have work ongoing with the NIH NIAID in African American men in low socioeconomic neighborhoods. We're looking at different combination therapy regimens with NIH and a variety of other programs, again, to try to identify and develop evidence for some harder to treat or historically harder to treat, harder to reach populations. Because as we move our way through the treatment cascade, we will really be moving into patients who maybe are not in care or not stable in care, and we'll need to generate the evidence to treat those patients. We're also, for example, working with a major HMO and trying to look at in a retrospective study over the last 10 years how treatment decisions were made within that population, who was treated, who wasn't treated, and why, and that may help to generate evidence to understand some of the triggers within the system that can help us bring more people into care and get treated. We're looking at people who inject drugs as another population that obviously has a significant need for treatment for hepatitis C, and one that is not well understood today. Again, we need to generate and like to generate evidence in that population. Another population is the VA, and so we're looking at within the VA system of data and evidence that can be generated within that population, including elderly veterans, and what we can do with that population to improve treatment outcomes for that. We continue to work in pre and post-transplant. That is, continues to be an area of significant need, as well as looking at the other genotypes, particularly genotypes 4, 5, and 6, which is probably more relevant in some of the international work, but we do have genotype 4, 5, and 6 patients in the U.S., and we'd like to generate data for those patients. So we have studies ongoing globally to look at those populations as well. We want to continue looking at HIV co-infection, so we're looking at more real-world settings to study that population and try to understand some of the challenges faced by those with HIV, hepatitis C co-infection. And then, I think a really important aspect is looking at long-term follow-up, and this is something I really would like to hear more from the other panels, how we can do that. We are really talking about registries, also working with closed systems to find out, as we achieve SVR12, what happens to these patients over time in terms of reversal of cirrhosis or reduction in hepatocellular carcinoma, reduction in other complications of hepatitis C. It's something we've been able to do in hepatitis B. It's something we've been able to do in HIV in terms of following those patients, but that's going to be data I think that's going to be critically important to us. And finally, and I'll close, but I just want to emphasize that we're also looking beyond clinical evidence, but looking at data around health economics and outcomes, patient-reported outcomes, and health-related quality of life studies. So we've done that. We've built those into our pivotal studies currently. So we have those data that have been and will be continuing to present to show the impact that treatment of hepatitis C will have on, again, health economics, to the systems, to the health-related quality of life of the patients, including presenteeism, fatigue, and other items associated with the patients, because we think those will be data moving forward that we'll need to generate to work with health systems to identify how to best manage patients and who should be treated earliest for therapy. So I'll stop there because I think I'm through with my time, and then open up for questions later. Thank you.
Thanks very much, Gregg. At this time, I'll go ahead and turn it over to our co-host, Steve Pearson with ICER.
Hi, everybody. You can advance to the next slide. So I'm obviously speaking for myself, but I am largely channeling the experience that I and ICER have had through our program, the California Technology Assessment Forum, or CTAF. CTAF is one of our major programs. It's funded by the Blue Shield of California Foundation. And just to give you a little bit of background, again, because I'll be talking a little bit about, again, not just my perspective on the evidence needs, but the perspective that arose out of the consideration of the existing evidence by the CTAF panel. So what happens through the CTAF process is that faculty within ICER and at the University of California, San Francisco, we produce evidence reviews on effectiveness, cost effectiveness, and budget impact. And then we convene an independent panel of clinicians and public members who meet in public to discuss the review and the information, and to take votes on the evidence to help guide decision making. Actually, as part of the public meeting after their votes, we have what we call a policy expert roundtable, where we invite clinical experts, but also experts from the payer community, manufacturers, sometimes certainly the patient community, and providers, to basically kind of discuss, given the evidence, how should we consider some of the best approaches to applying it to guide practice and policy. Next slide. So in March, CTAF met to discuss specifically cimeprevir and sivosbuvir for treating chronic hepatitis C. And it was a very unusual, I think, experience for the CTAF panel. If I can kind of try to read their minds as it was expressed, they were suffering severe cognitive dissonance, I think, in some ways, because they are used to looking at, challenging areas of evidence where, the evidence isn't necessarily that convincing, or it might be controversial for one or another reason, and that's why it's been a topic that they've been asked to look at. But they also rarely look at interventions that seem to have such a magnitude difference in terms of the effectiveness, safety, etc. So they were kind of trying to put these two features of the evidence around the new drugs and try to deal with it. They did express a lot of concern, though, about the evidence. They basically criticized it, or expressed concerns about the size of the trials, the fact that they seem to have very relatively small numbers of patients. They were perhaps most concerned about the lack of randomized trials for many of the genotypes, and that ended up with FDA approval. I would have to say I'm glad that we have Dr. Mishra on the call. The CTAF panel would have loved to have sat down Dr. Mishra or others and tried to understand further the FDA perspective on approving a drug without randomized trials, especially in some of these situations. So it's a dialogue that needs to happen, because I think a lot of people outside the regulatory worldview don't easily understand some of the reasons that go into the choice of what level of evidence will be accepted. They realized, the CTAF panel, that the trials were relatively short in terms of the duration. That's always something that they're thinking about in terms of the possibility of either effects or side effects turning out different in the long term. They had a hard time identifying subpopulations who might benefit more or less from treatment. And the classic concern of quote-unquote real-world decision-making, which is, do the clinical trial patients, doctors, settings, etc., have anything to do with the real-world outcomes it will get in the community. Next slide, please. So as I mentioned, they take votes, and again, despite a lot of concerns raised during the meeting, they voted a strong majority that the evidence was adequate to demonstrate the clinical superiority of the new drugs, with some nuances to their voting around certain subpopulations and regimens. They also, as I mentioned, consider information on budget impact and cost effectiveness, and they did vote, again, with strong majority that the drugs represented a low value to Medicaid health systems. That's the perspective we asked them to take, because the budget impact they felt would displace potentially other care and or limit access. Next slide. So in my trying to piece together both their concerns about the evidence and looking forward from that, and also talking to other groups, because what's interesting, CTAP panel in terms of their votes came down in some ways in the middle of some review groups. There have been others, such as the one in Oregon, which was much more pessimistic about the level of evidence. I know NICE in England has expressed a request for further evidence before it's going to make its judgment. The German agency has expressed some concerns as well. So there are a variety of different perspectives still on whether the level of evidence available on the new drugs is going to help make decisions. And hopefully a lot of those concerns can be translated into ideas for generating that evidence going forward. If I had to try to capture the 5 most important evidence needed going forward, one is still just a basic epidemiology of untreated hepatitis C in diverse populations. We may not have many untreated patients anymore, but basically there is still a felt need, at least in the clinical and payer communities, that there are patients, many patients who will do quite well without active treatment, at least in the short term. So there's a need to try to understand how those patients can be identified. There's a need for long-term outcomes, data on long-term outcomes of patients who do achieve SVR. I think, as Mr. Alton mentioned, there's a lot of hope that patients, once achieving SVR, will see their risk for hepatocellular cancer and other long-term outcomes revert to the baseline, but it's not 100% clear if that is the case. Number 3 is that we need a lot more data on real-world SVR rates, especially with enough patient information to facilitate robust indirect comparisons. And if I could put out a plea from the evidence review community, we know that in the short term we're unlikely to get a lot of head-to-head active comparator trials, and we know all the reasons for that. On the other hand, there are easier and much tougher data sets with which to do good indirect comparisons. And now that sivosbuvir and simepravir are out there, soon there'll be other choices. And patients, doctors, and payers are all going to want to know how these compare. To do that well, we need good databases that capture patient clinical characteristics in a common enough format so that we can do good indirect comparisons. We need real-world evidence on side effects and viral resistance. There's still, again, given the short duration that we've had so far, concerns about real-world viral resistance when patients may not be as perfect at taking all their medications as they've been in the clinical trials is something that people want to look for. And again, kind of a bit of a sidelight, but something that I hear clinicians talking about a fair amount too, is we need prospective trials of how to monitor patients who do opt, for whatever reason, for no active treatment at the time being. Should patients be monitored with liver biopsies, or are there other non-invasive approaches? And again, a lot of these can be done either through pragmatic RCTs or observational designs. So I'll stop there, and again, look forward to the other comments and the questions later.
Thanks very much, Dr. Pearson. I'll pause here briefly just to remind our audience members, please feel free to chat in your questions using the chat box on the left side of your screen. We'll be addressing your questions at the end of the conference after our speakers have presented and we've had a short panel discussion, and we'll get to as many of you as possible. At this time, I'll go ahead and introduce Donna Cryer, President and CEO of the Global Liver Institute, who will be our next speaker.
Thank you very much. So the Global Liver Institute is an innovation and collaboration platform for stakeholders across the liver community. We serve that community in 3 ways: by increasing the share of voice for liver issues in the global public health conversation, by facilitating collaborative approaches and knowledge sharing among patient advocates, policymakers, regulators, public health officials, clinicians, and researchers, not only in liver disease, but in therapeutic areas that are relevant to liver disease, such as HIV, inflammatory diseases, and oncology. And thirdly, by attracting and highlighting innovation, particularly digital and technical challenges that are facing liver patients. So I appreciate some of the earlier comments about patient-generated health data and workflow. So I speak today as a patient myself, being 20 years post-liver transplant, as a patient advocate and the leader of a patient advocacy organizations. And I wanted to make two primary points today for our general understanding of effectiveness and value moving forward. And it's less about the specific drugs at issue, but about this entire next generation class of therapeutics. So the 2 points are, as this slide really is focused on the who, and then the next slide will be, but don't go there yet, the next slide will be on the what, just to give you an overview. So who should be involved in demonstrating the clinical effectiveness of drugs in the liver space? Certainly, I'm very excited to have representatives from the Food and Drug Administration here. I also have the privilege of serving as a patient representative to the Food and Drug Administration, and so many of those points have been covered. So I'll focus my comments on the next three organizations: the American Association for the Study of Liver Diseases, the Infectious Disease Society of America, and the International Antiviral Society of the USA. I just wanted to underscore how unprecedented it is for not one, not two, but three medical societies to come together in a sense of collaboration and urgency, in such unanimity, to produce new guidelines outside of the normal guideline cycle, and to achieve a level of unanimity that is infrequently seen in any therapeutic area. And in my hundreds of conversations with hepatologists and gastroenterologists, the evidence that they have reviewed and their perspective of it has been deemed not only significant, but the word most frequently used is transformative. And so these are the organizations that have the expertise and the credibility and trust of the liver community well earned. And so to second-guess their judgment on clinical effectiveness, I think, is not a good use of our time and resources. I do want to point out that moving forward, it will be helpful to continue to generate more data from real-world uses in post-market surveillance, looking at observational and clinical data as we create more of a learning healthcare system. And I appreciate the comments about patient-reported outcomes being an important aspect of this. I also think that we will look forward to more comparative effectiveness research, whether that be head-to-head trials or other types of research that's done. And my points on those two types of research is that they be transparent in both the design of the studies themselves, as well as in the release and dissemination of the results. I think it's very important that in both cases, that these new studies, the new generation of evidence, needs to be created by multi-stakeholder groups, including hepatologists, including patients, so that the evidence that is developed will be seen as credible, relevant, and useful to the community. So my second slide, please. So in defining value, I first thought it might be helpful to have a definition of value, because often what we're hearing a lot of is cost effectiveness and not really value in the sense that it's been developing. Also, from a patient perspective, from which I'm primarily speaking, value is often different than those of other stakeholders. So I think we always need to keep in mind when we're using the term value, we're asking value for whom. So I wanted to just start as an overview with 2 quotes from Dr. Michael Porter from the Harvard Business School, and I use at the top of this slide his definition of value as healthcare outcomes achieved per dollar spent. But Dr. Porter goes on to say that achieving high value for patients must become the overarching goal of healthcare delivery, and I think that's been lost in the reports that I've seen so far. I would also quote Dr. Porter from his New England Journal of Medicine article in saying that total cost for the full cycle of care for the patient's medical condition and not the cost of individual services to be what we use to determine value. So with that, I simply wanted to go over some of the elements that we might discuss for creating effectiveness and value research moving forward that would be seen as credible, relevant, and useful for the community. So certainly the outcomes are several. Improved quality-adjusted life years is a valid element of outcomes. Increased SVR rates. The term cure is not thrown around lightly in any part of medicine, and so to see that used here and to validate it by the medical community is certainly significant. Increased adherence. I think that as mentioned earlier by some of the presenters, that the reduction in complexity of the medication regime itself can result in increased adherence, and that's validated in studies across different therapeutic areas. And so the real fear of developing resistance to these new medications can be reduced by increased adherence that we anticipate seeing from a reduction in the complexity from multiple injections over the course of several weeks and several days to pills, for example, when once daily uses. Reduce adverse events. And I think that often side effects is really too tame a term to use when we're discussing what happens either with the hepatitis C itself and with the previous generations of treatment. And so when we're conducting studies, when we think about side effects such as significant anemia, we use the term fatigue. It's not just being a little tired, it's having significant life-threatening, in some cases, anemia. And so when we look at the overall costs and cost effectiveness, we have to think about what the costs are of treatment for EPO, for example, which is a very expensive drug. And so if we're avoiding use of those very expensive drugs, chemotherapy, home care, we also need to think about, because of the severe side effects, lost income to both patient and family caregivers as part of our calculations. I think that's also important. Reduce progression of disease, less hospitalization, less cost of imaging, liver cancer medication, and transplants, which, as we know, even back in the day when I got them, were at least $500,000 in cost to start, and that's not even the years of maintenance afterwards. So I think if any valid study is looking at patient-level impact, needs to include patient-level cost. Health system-level impact need to have health system-level costs and offsets. And often, or in the reports I've seen so far, those have been, I wouldn't say manipulated, but they've been conflated and are uneven, and so the resulting reports are not well constructed in my view, at least not how they taught me at Harvard. And so 2 other points I wanted to mention in terms of looking at the overall global costs and the impact of disease and treatment to the entire healthcare system and in terms of our national economy are pointed out very well in Milken Institute's publications on the burden of chronic illnesses, and were referred to earlier. Reduction in absenteeism, certainly if you're taking 12 weeks off instead of 48 weeks off, from your job. Then there's increased productivity, lower turnover, and replacement costs to the employers who are often paying for this care. There's also, for many patients on previous regimens, there was not only the 48 weeks of treatment itself, but also recovery from the treatment. If that can be reduced, then that should also increase productivity. And then presenteeism is something that thankfully was mentioned here today. I rarely hear it mentioned in other conversations, but people who can't afford to take time on their job off of their jobs while they're going through treatment, but they have decreased productivity and there was the decreased economic growth. So if we can reduce that, we can, in fact, heal a nation. And the last point I'd like to, based on earlier comments, I'd like to mention is about the thought of watchful waiting. I think as clinicians anticipated this new class of drug, we have seen a lot of watchful waiting over the course of the past few years, and I've been involved in this community for 20 years. And I've never seen this done before to this degree. I think that unless there is significant amounts of informed consent, shared decision-making that's accompanied by very active monitoring of disease progression, so that is shared with patients, active waiting is really not something that is appropriate without a significant decision point by clinicians and the individual patient. Thank you.
Thank you very much for that presentation, Donna. Our next speaker is Dr. Michele Manos, who is joining us as a public health consultant and is formerly the director of the Kaiser Permanente Viral Hepatitis Registry. Thanks, Michele.
Hello, can you hear me?
Yes, we can.
Great, thank you. Thank you for inviting me to speak today and to give you my own perspective, and as well as the perspective I've developed in studying viral hepatitis C and B in an integrated care setting for almost 20 years now. If I could have the first slide. So I set my presentation up to move us from simplicity to, or relative simplicity to difficulty, and focusing on the things we need to know. I think from my perspective, and several of you have touched on this, we really need to be utilizing real-world or community-based findings to evaluate what our next steps should be with the new drug. And of course, things are not what they seem in clinical trials when one puts them into a community-based setting. And large population-based studies, such as those that can be done at the VA or in populations like Kaiser Permanente and other closed systems, are really crucial. Just reflecting back on the first generation direct-acting antivirals, the SVR rates, the crude SVR rates in the study we did were about 50%, and that's consistent with what's been seen elsewhere, and that is, of course, not what was shown in the clinical trials. I think even more important is that we need to focus on data from baby boomers in terms of priority and impact in the United States. Most of our hepatitis C patients are baby boomers, and they've now started to reach the age of 70. They're moving into Medicare, and they are the group that is the most likely to be approaching or already have disease. And so they're not always the group that are participating in clinical trials. So what are the specifics? Certainly SVR rates by age, by disease status, very importantly by race, by treatment history, and of course, as we start to understand more about both host and viral genetics, that's important. Now, perhaps side effects will become less important as we start to move into novel therapies, but we still need to be paying attention to these. The prevalence of them, the severity, the cost of taking care of them, and of course the discontinuation rate due to side effects. And very importantly, we really need to understand which side effects are attributable to interferon versus ribavirin. Right now, we're still using one or both of those drugs in addition to the novel agent. And as we all know, both of those cause severe side effects. And I think it's also important to realize that just because we're using a shorter duration of treatment, let's say 8 to 12 weeks, that doesn't preclude the huge impact of ribavirin and or interferon, because the effects of those drugs happen, and they happen hard and fast within those first 12 weeks of treatment. We have various potentials for a shortened duration of treatment. I think we really need to understand how flexible that is. If someone's really having a hard time at 8 weeks, can we stop them then, for example? And then of great scientific and practical interest here is, what are the long-term relapse rates? There's a lot of question about whether in the absence of immune stimulation, that is the use of interferon, do we risk suppressing the viral infection rather than completely curing it? And I think that remains to be seen. Next slide, please. So getting more difficult now. We've touched on this earlier in this panel. Can we quantitate the long-term benefits of treatment? Certainly my group has done this from a cost basis and also a clinical basis. And this is something that should be assessed in community-based settings, and importantly, again, focusing on populations that have your average baby boomer there, because that's, again, the largest group. So how do those benefits of treatment vary by patient characteristics, race, viral genotype, other comorbidities, the stage at which we were able to successfully treat them, and then does everyone benefit, or is there some drop-off point or point of no return beyond which treatment isn't going to be beneficial and maybe actually detrimental to the patient? And then, very importantly, who needs treatment and when? We focus a lot on disease status. I think everyone is focusing on patients with more advanced disease right now and prioritizing them for treatment. But what about additional risk factors, and what about age? Again, the largest group are baby boomers, and we're not getting any younger. And so we're looking at treating older patients. So again, this ideal time to treat. And is there a subset of patients who will not progress and have less of a requirement for therapy, at least at this point in time? And then this upper age limit for treatment question is going to become more and more important again as the baby boomers are not getting any younger. Next slide, please. So I see this as an extremely large challenge, and it's often the case we have to determine how to best distribute limited resources. I think this is true in every situation. And at this time, as we're all acknowledging here, we have limited information upon which to base those decisions. Just to remind us that population health perspectives and decisions are distinct from clinical choices of patients and clinicians about the treatment of an individual. But I believe if we don't act soon, the huge majority of patients will age out of the window for intervention, and we will have many people in the baby boomer generation dying of liver disease. I think what's really key, and we haven't talked about yet here, to being able to do this, is funding. These types of studies that allow us to show things like the fact that when a patient has SVR, their risk of hepatocellular carcinoma goes down at least sixfold, and things like this they're difficult to do. They require large numbers, and I think we all realize that the NIH hasn't made a large investment in this type of work. They have a very limited portfolio in hepatitis C. And And I think we really can't depend on industry to be funding all of this. It seems to me we need to keep up the pressure, but also become more creative. The agency that's going to be the most impacted by this is Medicare. And so can we turn to CMS or perhaps to AHRQ to get them to become larger participants in making sure we get the information that we need to move forward? And I'll stop there. Thank you very much.
Thank you very much, Dr. Manos. Our next speaker is Dr. David Ross, who we're pleased to have joining us here at our Baltimore offices at CMTP.
Hi, everyone. Thanks. I just want to start with a disclaimer. The views that I'm expressing are not necessarily those of the U.S. government or the U.S. Department of Veterans Affairs, but they may be. So having said that, let me give the VA perspective, and I will try and do so succinctly. We take care of about 5% of the country's HCV patients, about 175,000 in care. Our population is like the U.S.'s population, but more so. We have high prevalence rates not only in VA, about 3 to 4 times higher than the general U.S. population, but we have very high prevalences in patients with substance use disorders, mental health disorders, alcohol use disorders, and homeless veterans. 2 VA studies have found a seroprevalence of over 40% in homeless veterans. Next slide. Currently, our approach is as follows. A, we are extremely excited about the potential for these drugs to reduce death and suffering due to HCV, not just at the payer, provider perspective, but also, as Ms. Cryer pointed out, taking the societal or patient perspective into account. First and foremost, I want to say that although these are obviously expensive drugs, cost is not a factor in treatment decision making. And there's going to be a formal statement on that issued relatively soon, but I can tell you that that is certainly what our policy is. And that I actually do speak for VA. Sofosbuvir and Cimeprevir were added to the VA National Formulary in March of 2014. We also, my office produced updated treatment guidelines a few months ago, and these are based on the FDA reviews. Certainly we considered the guidelines issued by our colleagues from the ASLD, IDSA, IAS writing groups very carefully. We are continuing to monitor drug uptake and outcomes. I'll show you some data on that in a minute. We also, though, want to focus on treating comorbidities. Thinking about the value of these drugs, it doesn't do a patient if they don't die from liver cancer due to HCV, but they do die from liver cancer due to drinking. And a lot of our patients are not able to get treatment or haven't been able to get treatment because they drink, they use injectable drugs, although the question of whether that should still be a barrier is ongoing. We're focusing a lot on provider education and data feedback, but we also are doing a lot of work on system redesign. I'll show that in a minute. Next slide. So right now, and this is a slide that's a few months old, but this shows the uptake of Sofosbuvir, Cimeprevir, and the combination used compared to Boceprevir and Telaprevir over corresponding periods of time. And at the time, this was 90 days after FDA approval. At that point, we had something like over 900 patients. At this point, we have over 2,000 patients who've been started on one of these drugs. And I'll just say, for example, we have at this point more patients on soft sim that have than were in the clinical trial, the ongoing clinical trial, looking at those that the FDA reviewed in part, although not for efficacy, and which is now the subject of a supplemental NDA. Next slide. So what are the questions we're interested in, and how are we approaching them? We're trying to go beyond the important question of effectiveness to how do we improve access to HCV treatment for veterans with geographic or other barriers. There's some regions of VA, for example, the Midwest, where 45% of the veterans with HCV live in rural or highly rural areas. Secondly, how do we redesign care to increase capacity? As many of you are no doubt familiar with the work of Sanjeev Arora in New Mexico and Project ECHO, and they have, when I was there last, 3 hepatologists for 34,000 patients. VA is in somewhat of an analogous position. There's not enough hepatologists in the known universe to treat all the hep C patients. So what do we do about that? And then just to go to some themes that were expressed before, what is the real-world effectiveness? And I'll show you some data related to boceprevir and telaprevir on that in a minute. What is the comparative effectiveness of different DAAs? And what factors predict adherence? I absolutely agree that as we get out into the real world, this is like any other infectious disease, especially tuberculosis or HIV, where combination therapy is required, and you can see rapid emergence. It's an RNA virus. It's going to mutate or have unfaithful replication very rapidly, and we'll see resistance. So the way we're approaching this is primarily at this point through cohort studies using the VA's HCV registry. And this kind of technique has been used very, very successfully. For example, Dr. Manos had really some very important work that she published about a year or two ago. Michele showed that there's a downstream cost impact, positive cost impact from SVRs. So if we go to the next slide, we can use our registry data to actually geographically map where HCV patients are. So this shows where patients with Hep C are in Colorado relative to the Denver VA. My colleague Susan Kirsch of the Cleveland VA set up satellite HCV treatment clinics staffed by primary care providers who had gotten training. And A, we're able to treat more patients, and B, we're able to significantly reduce patient travel, which is a huge barrier. We're trying to replicate this throughout the system. Next slide. If we look at the issue of comparative effectiveness, and this is data from my colleague Lisa Backus out of the Palo Alto VA. This is a publication that appeared in January. They looked at telaprevir and boceprevir, not in a prospective head-to-head trial, but using essentially risk adjustment with a cohort. They found a number of interesting things. First off, as you might expect, SVRs were lower in the real world than they were in clinical trials. No surprise there. They were higher than the historical controls. And I think Dr. Pearson raised a number of very important points. I think that HCV, because of the availability of large databases that can sufficiently robust and have good quality data, we can use Pocock's criteria for historical controls and really say, with a fair degree of confidence, what's the relative efficacy of these drugs. So telaprevir, for example, in clinical trials had a SVR rate of 79%. In the VA, it was around 50-52%. But what was interesting is, in this paper by Lisa Backus, if you look at confounders and you adjust for those in a multivariate analysis, telaprevir actually was significantly more likely to result in SVR than boceprevir was after you adjust for things, other predictors. I think this is particularly important because I want to address one issue that was mentioned earlier, which is the issue of potentially using non-inferiority trials. And while there is certainly a role for non-inferiority trials, I am very hard-pressed to think, as both a clinician and a healthcare quality person, why in the world I would choose to pay more for a new drug that was approved through a non-inferiority trial. By definition, it is not any better than the comparator drug. And arguing that because of some secondary characteristic that was not tested in the clinical trial, it's better, really says to me that the company did not feel comfortable going head-to-head and trying to show their drug is better. Next slide. Other questions, and this is my last slide, that may be useful for people to think about. First off, can patients with these traditional barriers to treatment be treated successfully? Question of whether SVR as a surrogate endpoint is the same even if we're using DAAs, I think is absolutely central. There's a classic paper by Tom Fleming and Dave Demetz from the Annals from 1996 showing that if you get the same result with a surrogate endpoint through different mechanisms, your clinical outcomes may be very, very different. I mean, certainly that's been shown over and over and over in multiple settings. And I'll just mention in HIV, darunavir, Prozista, which is a very good drug, but it met its surrogate endpoint of decreasing viral load in the clinical studies, but it actually increased the mortality rate. So ultimately, drugs, people don't come in saying, gee, my viral load is up. They come in saying, I don't want to die. What is the utility for treatment of different populations? This gets to the question of watchful waiting, and I think we need more data on that. And then finally, we're seeing a very scary increase in infection rates among IDUs. Are there any prevention benefits from treatment, regardless of stage, or from post-exposure prophylaxis? Trying to think beyond this. Can these interventions to increase access be extrapolated to other therapeutic areas? We've seen in the VA that mid-level providers get SVRs with VA patients that are the same as MDs, whether they're primary care providers or hepatologists. What are the pros and cons of this drug development model for other therapeutic areas, particularly antibiotics? And again, I'm raising that because a lot of people say, well, antibiotics, we've got a great surrogate endpoint, in vitro susceptibilities. That's a terrible surrogate endpoint. Dr. Mishra, obviously I'm not trying to put you on the spot, but please take that message back to Ed Cox. And then finally, payers. I think one thing I've heard from payers is how can we understand better what's likely to happen with costs, especially when we've got, we can't get hit suddenly every 6 months as new regimens come out. And then finally, if we're looking at these very large populations, is traditional cost-effectiveness modeling the right way to go, especially if, as Ms. Cryer said, we need to think about other issues such as essentially the societal perspective. I'll stop there and happy to answer questions later.
Thanks very much, David. Our final speaker today is Mark Godwin, who is the Manager of Clinical Pharmacy at UnitedHealthcare.
Yes, good afternoon, everyone, or good morning to our West Coast colleagues. And I want to thank CMTP and ICER for inviting UnitedHealthcare to participate in this collaborative discussion this afternoon regarding the evidence needed to demonstrate effectiveness and value for new drug treatments for chronic hepatitis C infection. UnitedHealthcare is committed to providing affordable healthcare benefits and as such actively monitors the development of new clinical evidence and availability of new products which may help lower overall healthcare costs. The recently approved medications for hepatitis C, as well as those currently in the development pipeline, offer the promise of lowering the long-term healthcare costs associated with hepatitis C infection. However, additional evidence is needed to document this impact, as well as to help shape coverage policy decision-making moving forward. So in preparing for our conversation this afternoon, I did survey the UnitedHealthcare clinical team, which is comprised of medical directors and clinical pharmacists such as myself, so that we can provide you with our key recommendations for future research efforts. Many of these you will see echo many of the prior speakers in some of the key themes here. So next slide. So what we see really as key areas that we would like to see future research effort focused on would be the long-term SVR12 durability data. As Dr. Manos pointed out, do we have long-term consequences potentially from removing the immunomodulating effects of interferon? As well as having comparative studies designed to help us identify the most effective DAA combinations based on patient characteristics, disease staging, and then regardless of manufacturer sponsor. This would include both comparative clinical outcomes, intermediate and long-term, as well as comparative cost outcomes. And we do feel like there's additional data on specific subtypes or subpopulations within the hepatitis C population that we would find of interest. Next slide. Again, this was echoed by our prior speakers that especially in the payer community, studies designed to help us determine when the appropriate time to initiate treatment is. Long-term data and outcomes for patients that achieve an SVR12 or 24 extrapolated out and sequenced so that we can see it based on fibrosis score at the time of treatment initiation. So that we can see for those patients that do achieve an SVR, is there a difference between therapy initiated an F1 versus, for example, an F4 Medivir score? And this research must highlight the degree of fibrosis at the time of treatment initiation, again, so that the stakeholders can help best determine the most cost-effective and clinically appropriate time to initiate treatment. And then lastly, pharmacoeconomic studies that would be designed to demonstrate the true value of DAA treatment regimens. These studies should include both pharmacy costs as well as the medical cost savings. This could be done either through post-marketing studies or potentially a registry database that could track long-term medical cost savings. And we really feel it's important that any pharmacoeconomic study consider the all-in cost of treatment, including the comparative cost effectiveness of each drug, as well as drug combination, as well as those respective costs in relation to medical costs and then resulting medical cost savings. And with that, I'll turn it back over to the presenters.
Great, excellent. Well, thank you all for keeping to time and really focusing on this on these questions of thinking about the additional evidence that would be useful going forward. We had quite a good supply of questions submitted, and I'm going to try to stick with those as much as possible. So let me just start off with Dr. Mishra. Actually, I was just going to direct back to you I think a comment that Dr. Pearson had made about providing a little bit more context and explanation for the decision about a historical control for the pivotal trials, and just I think it'd just be interesting to get some additional insights around thoughts at the FDA and with your various public meetings about that choice of a comparator for the primary studies.
So as I said earlier, we have been in continuous dialogue with numerous stakeholders involving academia, patient groups, advocacy groups, pharmaceutical companies, and after taking input from all these stakeholders, we thought that since SVR is such a highly objective endpoint and the response rates, as I said, of these new therapies were so much higher than the previous therapies that we thought that a historical control will be well justified and was a robust trial design for these trials.
Okay. And one of the webinar participants also had a question for you, Dr. Mishra. The question was, how soon after the approval of these drugs would the FDA expect to see SVR data in larger African American populations?
So we have been encouraging all the pharmaceutical companies to enroll a large number of African American populations, and we have seen promising increasing enrollment. So Going forward, we do think that we will have large number of these subpopulations represented in registrational trials.
Okay. And then one more question for you, Dr. Mishra, is it was a question about, given the phase 3 experience with Cimeprevir, why was there a requirement for a controlled study in contrast to the requirements for Sofosbuvir? Is that something you would know about?
Can you repeat the question, because I think I'm not clear on the question itself.
Okay. Well, I'm interpreting from the question that there was a controlled study required for Cimeprevir, that the FDA requested a controlled study, and the question was, why is that being handled differently than Sofosbuvir?
It depends on the clinical development program, and with such a rapidly shifting landscape of the development, we usually initiate early discussions with all the sponsors, and there must be some reason. I don't recall what the exact trial designs were for these individual drugs, but usually they are discussed in depth with the pharmaceutical company which is sponsoring the trial, and other than that, I just don't recall the details of the trial designs for these specific drugs.
Okay. Gregg, Alton, we had a question for you. There was a question about what was to clarify the purpose for studying hepatitis C patients who were active intravenous drug users.
Well, I think the purpose for that, and I forget the other panelists who mentioned that, there is a question of whether or not we should be treating those patients with hepatitis C therapy today, or whether we should require those patients to be on methadone and be off of their injecting drug use. That is an evolving question, questions of reinfection, questions of whether or not those patients will be adherent to therapy. And there's a personal view I have, or a personal hope I have, and this doesn't reflect Gilead, which is I hope and I believe we should be treating those patients, because I think if we're going to exclude them from access to the newer HIV therapies, it's going to make it harder for us to reach those patients. It'll create stigma among that population that already exists, but will reinforce that stigma. So my hope is that we will show that we can treat those patients effectively, and maybe in doing so move them over to methadone treatment and off of their risk behaviors. And then I think we also need to evolve into studying treatment as prevention with that population, because we don't know this well today, and I think we do need more epidemiology, talking about other evidence we need of where the new infections are coming from. But there are many who believe that many of the new infections are coming from the people who inject drugs. And so I think it's a good area for evidence and research for us.
Yeah. Okay. And Gregg, another question for you. Can you reflect at all about, given that there's going to be, products on the market from other pharmaceutical companies, can you just reflect on the issue of how the challenges and opportunities for comparative studies that might actually involve, products from different companies? How can that be handled, given that a lot of folks have identified comparative studies as one of the important areas for future research?
Well, I mean, it's we're kind of commenting about the future, so it's hard to say anything with any definition. But I think that as an industry, we tend to compete on data. That is what we do. That's what we do. I think it's the right thing for patients in this system. And I think that where comparative studies will be necessary to really tease out the differences in whether it be subpopulations of patients, or whether it be in long-term efficacy, whether it be in safety, what it may be, I would expect to see those studies. And whether or not they're done by industry or whether they're done by groups outside the industry will remain to be seen. But I would, if you just look at any other disease area or any other drug development, you tend to see those comparative studies occur when those products are on the market and really trying to define themselves.
Okay. Dr. Pearson, a couple questions for you. One listener had asked if you could say a little bit more about a little bit more explanation for why the conclusion of the panel was that the drug therapy was low value, and just give a little bit more insight into how the committee's discussion and that conclusion.
Well, I don't, obviously, thanks. I don't want to spend too long on that because it's not really forward-looking to that extent. Although it gets in a little bit into some of the economic data that might be collected going forward. But it was, again, trying to reflect the discussion and their votes. I believe that the evidence that they looked at included both kind of what would be classically called cost-effectiveness information, looking at the cost per additional SVR. We chose to do that instead of cost per quality because we felt that it was more reliable in terms of the data we could bring to the group in the time frame that we had. And they were provided budget impact analyses with different scenarios for the percent of patients who could be treated with the new drugs and what the different budget impact would be. So when they looked at both of those together, and they discussed a little bit their votes as they were occurring, it seemed that it was the budget impact more than the cost per additional SVR that they were viewing as low value. And again, low value we were asking them to think about the perspective of a Medicaid program with a relatively fixed budget that would have to incorporate this treatment at this cost. And so it wasn't just a consideration of the relative benefit brought to individual patients or to all patients treated. It was, in a sense, harking back to the population perspective that Dr. Manos mentioned. What might have to be displaced by that budget impact? Was it even remotely feasible to try to reach out and treat all patients who could potentially benefit? So it was into those lines of reasoning, I think, that they ended up voting low value.
Okay. And then I know you had a nice slide that sort of identified some of the kind of high priority areas for future research, for future evidence development. Can you kind of pinpoint the one or two areas of uncertainty that kind of rose to the top in terms of, would add the most, value in terms of, future decision making if you were to do an updated report, say, in a year, what would make the biggest difference?
Well, actually, CTAP will be revisiting this area when the next cycle of new drugs are coming out, so it's something we are thinking about. I would say probably the two things, if I had to guess. One is, and others have mentioned these, the continuing hope that there will be better data on subpopulations. We always know that early on we don't know as much as we will know later about which patients stand the greatest chance of truly benefiting the most from treatment. And given that there will be continuing questions about when and with whom to initiate treatment and with what, it'll just help to have more subpopulation data to the extent possible. And that's probably not going to come out of randomized controlled trials done for FDA approval, so it'll have to come through another source. But I would also say that because a lot of at least payers and clinicians and patients have to make judgments about these treatments relatively soon after FDA approval, it's great to talk about forward-looking data gathering, but if I could pinpoint one thing, it would be to really probe whether placebo-controlled RCTs would be feasible for the FDA to consider. It may be that there are going to be no patients left who would be willing to do that, but if the regimens are only 12 weeks long, see, the problem is that, and I appreciate this, the FDA's job is not to think about comparative effectiveness necessarily, and so if they have evidence of SVRs in phase 2 trials that are up in the 90s, it seems hard to justify a placebo-controlled trial. On the other hand, when we were looking at the data just on sivosbuvir and cimeprevir, when there were a couple of placebo-controlled trials, the SVR rates in the placebo arms ranged from the 40s to the high 50s. That may not seem like a huge difference. But when you're then comparing active control arms with SVRs in the mid-80s to high 90s, it starts to make it really hard to do the kind of indirect comparisons that patients and clinicians and payers are going to be interested in. So just a few placebo-controlled RCTs would make a huge difference in being able to compare the relative effectiveness of these different treatments, all of which obviously are starting to look quite good. But there's going to be a lot of interest in trying to compare them.
Great, thank you. So just, I know we have just a few minutes left, so let me just make a quick process comment. A number of folks have posted comments about the inability to kind of interact in the discussion. You know, unfortunately, with about 200 folks on the line, just under that, it's not sort of logistically feasible to have, you know, an interactive live discussion. And also, there's a lot of great questions that have been posted that we're just not going to have the time to get to. What we are going to do is we will post, once we have permission from all the speakers, we will post all the slides on the CMTP website. We will also be posting the full webinar on the website, and, on CMTP's website. And there will be, we're going to try to set up an email address for submitting your questions, and we will make an effort to see if we can get each of the relevant speakers to respond by email or in some kind of a blog or kind of bulletin board setup. So we'd like to be able to continue the conversation going forward. And so just check our website in the next couple of days, and there'll be a place to submit questions as well as get access to the slides as well as the full webinar. And so that's, just look up Center for Medical Technology Policy, and we'll have it posted there. And we'll also talk to our ICER colleagues about how best to cross-post. I have a quick
Sean,
question. Yeah.
This is Donna Cryer, if I may beg indulgence as the patient. May I ask a question of my fellow panelists? Because, and I ask this to guide evidence generation moving forward and make sure that we're not going down rabbit holes or asking false questions with the limited resource dollars that we have, research dollars that we have. Can the other panelists provide an example of an infectious disease that we do not treat? Because I find it sort of rather a false question about who do we treat and when do we treat an infectious disease, and perhaps my medical historical knowledge has a gap in it, but I'm not aware of an infectious disease that we do not treat.
Hey, Donna.
Treatment available that has at least a 40% differentiation in response.
Right. So let me just we're probably not going to get into that just because it's not really focused on evidence development directly. But let me ask you a question to respond to, just and then we'll have I have a final question for Michele and David and Mark to give quick responses. So Donna, you had mentioned several professional societies that had quickly changed their guidelines. And I'm just wondering whether you think those societies might be, willing to collaborate with various other folks, on the phone and others, to kind of get involved in the work to address some of the questions that have been, raised in this discussion. Again, taking your point that we know a lot already, but of course also taking the perspective that it's always helpful to know more going forward. What are your thoughts about, your organization and those professional societies being kind of collaborators on helping to gather some additional evidence going forward?
Absolutely. The Global Liver Institute was designed particularly as a collaboration platform. We have several ASLD members on our board, as well as members from primary care organizations, to the point of we need more people to be able to treat these patients and to understand the implications. So the answer is yes. I do believe that the community as a whole is willing to collaborate in future developments of evidence.
Okay, great. And if we can go just a couple minutes over, unless we're prohibited, I will just ask Michele, then David, then Mark. Just, a number of questioners have pointed out, wondering where the funding is going to come from, the data is going to come from, basically how, logistically and practically might it be possible to generate some additional evidence to address the kinds of priority questions that have been pointed out. So just love very practically, even from your own institution and work you're involved in, what mechanisms do you see as helping us move the research forward? And start with Michele.
Well, I think I pointed to several of the ideas. I mean, I do think that we have to get all levels of health and human services involved in, making this an urgent priority. But I think we've been trying to do that for quite a long time without any success. A lot of the funding that went into developing our large registry, all of it actually, has been cut. So we're no longer funded by our institution, by Kaiser Permanente, to maintain the registry. All of our information was pulled in to serve for practical clinical applications. And so I think, certainly in our institution, the party's over in terms of having the healthcare provider support this resource. So at least for us, we have to have other things. I don't think the VA is the same way, but I do think we need to have outside funding and some continued funding from industry, which we have had the blessing of through the years as well.
Okay, thanks. David?
So I think there's a number of possible mechanisms. One that comes to mind, and this happens a lot in the oncology world, is with the cooperative oncology groups, they don't generally look at new NDAs, but certainly a lot of the work that they've done on existing agents to look at just the kind of details we've been talking about subpopulations or new formulations or durations or whatever. That kind of model has been really, I think, very successful. I think that's number one. Number two, I think that pharmaceutical companies, if suitably incentivized, will do it. I think to get to just one example, the question came up, could we do a placebo-controlled trial? That's done all the time at FDA and other therapeutic areas. So, for example, if you look at antihypertensives, where you don't think you've got a high likelihood of a bad outcome over a brief period of time, that happens all the time, even in treatment of serious diseases. So there would be no regulatory or ethical bar to that. The FDA does it all the time. I think, though, that if the FDA doesn't require it, then the question is, why should the companies do it? And I think the answer is, if payers say, it's great that FDA approved it, that you've got some kind of interesting academic result here, but you know what? We want something that actually is applicable, that data that we think really makes it worth our spending the money, especially if you want a premium. The same goes for head-to-head trials. Again, I think there is definitely a role for head-to-head trials. I really think that non-inferiority trials have to be considered very carefully, because if you're going to not show that a drug is better, then I don't know why a typical PBM or provider who's responsible for costs would say, why should I use this drug?
Yeah, great.
Up there.
And we'll give Mark, you get a last brief word. Mark Godwin.
Yeah, so I think from the UnitedHealthcare perspective, we have numerous stakeholders and customers that we serve, self-funded employer groups as well as state Medicaid agencies, as well as our collaborative work with CMS in the Medicare Advantage and Part D space. So for us, I think it is just engaging all these stakeholders and working collaboratively together to kind of find solutions and improve access to care. And we've begun those discussions, and we continue those, and we will look forward. As you mentioned, we would much like to see AASLD, IDSA, and the professional societies work collaboratively with the payers to try to come up with the best ways to move treatment forward.
Great. Okay, really appreciate that, and I just want to thanks everybody for participating. fantastic speakers, presentations, a really good discussion. Again, I apologize to the participants that we didn't get to more of your questions and have the ability to do live interaction. As you'll see on the slide, we have an email address for Els Houtsmuller. You can send her any comments or questions. We'll make sure they get responded to by an appropriate speaker, or we'll try to respond. And again, we'll have the slides as well as the webinar posted on our website, for which the web address is listed there. We'll also plan to continue the conversation with our colleagues at ICER and see if there's some way that we can actually be proactive about exploring the kind of collaborations that people discuss to pursue some of this generating the additional evidence. So again, thanks to everybody, and we appreciate your participation.
Thanks.